Hello everyone. So we have the pleasure of having two invited guests today. We have Dr. Peter Kahn and Dr. Jared Knopman. Dr. Kahn, he did his undergraduate studies in McGill in Canada, did his medical school in Toronto, a neurosurgery residency in the University of Utah, and completed a fellowship in endovascular and cerebrovascular neurosurgery in Buffalo. He has been in Houston for the past several years,
6 years, yeah, over 5 years, yeah.
Over 5 years, and actually today, he's his first day in a new job. He's now the chairman of neurosurgery at UTMB in Galveston. So congratulations, Peter. And it's a pleasure to have you here. You are obviously a leader in the field, and your interest in the subject matter that we're discussing today, endovascular treatments for subdural hematoma, has led you to have a major paper accepted to the Journal of Neurosurgery, and about to start a new clinical trial, NIH-sponsored clinical trial. So congratulations on that. And we also have Dr. Jared Knopman. Dr. Knopman completed his bachelor's degree at Northwestern University. He did his medical school at Mount Sinai here in New York. Completed his residency in neurosurgery at Cornell, New York Presbyterian Hospital, and an endovascular interventional neuroradiology fellowship at Cornell. And it's a pleasure to have Jared join us, again, talking about this subject today of interventional treatment for chronic subdural hemorrhages. Jared was the person that came up with this idea on how to treat these patients with endovascular techniques and trying to get away from burr holes or craniotomy. And now we're joined also by one of our partners, Jason Ellis. We would like to start with Jared and listen from you. How did you and your team come up with this technique? How did you think that it was something possible? So, classical teaching was that epidural, yeah.
Guys, we also have an audience that's not on this, an Instagram audience. It's up to about 100 kids right now. This is part of our summer internship, our virtual internship. So just use that, as far as you talk. We have a bit of a lay audience in addition to the usual higher end. So just when you speak, just speak to that a little bit, because we have a fair number of college, high school, med school level that they're participating. I think we're up right now, we've about 90 or so on Insta. So this is a good opportunity for you to talk about, at a high level, but also respect the fact that we have people that are learning for the first time about this entire procedure, why it works. And that's a unique opportunity for all of us. So I'll leave it at that. So go ahead, Raf.
So going back to the classical teaching was that epidural hematomas were caused by arterial bleeding, and venous hemorrhages led to subdural collection. So and now we're treating arteries to cure subdural hematoma. So what was the thought process, Jared? How did the team come up with this idea, and how did we end up where we are today?
Thank you for the opportunity to speak and the invitation. So yeah, I mean, you're right. For half a century, we've always learned that subdural hematomas were caused typically after an elderly person may trip or fall or hit their head, and the space between the brain and the covering over the brain, which is called the dura, naturally enlarges over time. So if someone falls, a little vein that's traversing in that space can get torn, and that leads to bleeding. And the way that I think we thought about arteries playing a role in this was really just how we used to have to treat these day in and day out. Those of us who routinely operate on these have found that subdural hematomas over time generate this membrane, this film around them. And the film is very friable, meaning that the membranes, they tend to ooze blood. And when we would take these out, there was about a 15 to 20% recurrence rate in the literature. And it's typically because the ooziness of those membranes doesn't stop when you take out a subdural hematoma. We may take the pressure off the brain, but the underlying ooziness can cause recurrences. And there had to be something that was feeding these membranes to cause them to be oozy. And the only artery really in that territory is the middle meningeal artery. I started sending pathologic specimens of those membranes to our pathologist, and indeed we started seeing small arterioles running in those membranes. And we oftentimes will see patients with chronic subdural hematomas that may have fallen once 3 months ago, but they have blood on their scan that's really of mixed age, meaning that they have new blood, old blood, blood in sort of the medium term. So why is it that someone who fell 3 months ago would have new blood? Well, that basically supports a hypothesis that they're having these spontaneous hemorrhages, which cause these subdurals not to go away. And again, the things that tend to cause spontaneous bleeds are things that take blood flow, and arteries take blood flow to these membranes. I had read one paper out of Asia about 5 or 6 years ago of a physician treating a multiply recurrent subdural hematoma with embolization. So that really got me thinking about an arterial pathogenesis for this on sort of an epiphenomenon level. Could we intervene upfront for symptomatic patients instead of operating? Could we take patients who we had to take the surgery because the hematoma was big and they needed the pressure relieved, but then add an embolization on to prevent recurrence? How much can we influence the natural history of this if arteries really play a role? And that's really what spurred the idea to try to apply this technique, which we've been doing for decades for other things like benign brain tumors, and just apply it to a new disease state and see if it had an impact. And obviously we'll get to the data, but we've been really pleasantly surprised by how we've been able to change the natural history of both upfront treatment instead of surgery, as well as an adjunct to surgery to prevent recurrences.
I thought that it was because you thought that opening the head was barbaric and doing a catheter procedure was more elegant and more up to date. But
well, there's no doubt about that. I mean, but you raise a great point. You know, all these patients are older, and older people don't do well with surgery. You know, even a small burr hole in the skull places added risk to this patient population. Anesthesia is a risk. Laying in the ICU flat in the bed after surgery for a day or two is a risk for an infection or a pneumonia or a clot in the leg. Air in the brain is a risk. So the least you can do to an 80-year-old, if you can offer a minimally invasive treatment that obviates the need for anesthesia, obviates the need for an ICU stay, I think you cut down on all the morbidity that surrounds this disease outside of the hematoma itself.
So how long have you been doing these procedures for?
We started doing this about 3.5 years ago. We published our first series then, and we've since done about 250 patients.
Wow.
I heard Jared give a talk at, first of all, for the audience, there are some questions. One right now is about when patients are on anticoagulants, which we'll get to. But I heard Jared give his talk at the CNS. I can't remember what city. And you know, I knew he's you don't make this stuff up. And you know, it was the typical, whenever you're the first one to think of something, and this goes to the audience, to really inspire and to educate and get people to come to your side, especially in science, is hard. When you have a new idea, immediately the conservatism and the conventional wisdom of the world is against you. And I think that you need to be given a lot of credit. I mean, there was a lot of this can't work. How do you know? These would go away on their own. I think Peter will tell us about his study. But long story short, I think you represent, in our generation, it doesn't happen that often where somebody comes up with like a brand new idea that really flips the conventional wisdom on its head. And not only that, but opens up, and the reason why old people they come back. I mean, these atrophic brains, they very often, aren't great surgical candidates for a variety of reasons. So for the group, I think Jared and Peter, for that matter, represent, and Rafa, represent people who are really thinking outside the box. And it's really easy to do the same straightforward things and do the same things over and over again. But some of the best, most interesting contributions are made by people who do things that are against the grain and maybe not everybody believes in. I think that's the purpose of, perhaps this seminar today in the setting of what we're trying to do with our students right now. So thank you, Jared. I mean, I remember calling you afterwards and saying, we're going to try this. And, Rafa looked like I was crazy the first few times I did this. And I kept showing him films like, this actually seems to work. And I think, we probably have treated upwards of probably 30 cases, 30, 40 cases in the past, year and a half or so. And we've seen some failures, but the vast majority of patients have done really, really well. And I credit that, listening to that one day and having that talk with you, it really set us on this pathway and led to this conference directly.
Thank you.
As a parenthesis, we want to encourage the students and the entire audience to send their questions through the chat option so that and we will address them. So Peter, what has been your experience in the management of these patients? First the surgical approach and then the endovascular approach.
Yeah, so first one to try, really want to credit, I think really goes to Jared. And I remember the CNS that David is talking about, I think it's in San Francisco actually. And I think so many people came out and said, hey, the best talk I heard was from Jared. I think it was actually like a morning in the plenary session, presented his paper on the 60 patients. And I think that really sparked a lot of interest in that conference and to a lot of us kind of adopting the technique after that. So, as Jared mentioned, I think the history of this has been frustrating, right? For Jared, Dave and I who do these surgeries, the issue is the recurrence, whether you do the burr hole. You guys hear me okay?
Yes.
So whether it be the burr hole or the craniotomy, the recurrence rate, you look at literature, is close to 25% or so, maybe a little bit lower than that, but not that much, So 1 in 4 people needed something done afterwards, and some of those people shared operations. So I think the disappointment comes from the recurrence, and I have to say, even though to this day, I know Jared is of course heading up a randomized trial right now. We don't have that level of data yet, but I mean, all of us, Rafi, you, David, Jared, and I, Jason, we've all done these procedures. And I think anecdotally that worked. I mean, we just got a paper accepted in neurosurgery. We did like 150 plus embolizations, and the results are quite good. And in fact, they mirror what Jared has published a few years ago in his large series. I think you're talking about like the recurrence rate of really less than 10%. People needing another procedure after this. And also the reduction on the scan has been quite dramatic. About 70+% of patients have a 50% or more reduction on their scan. So I think the results are good. I've been very happy, Rafi, with, since I've started doing that.
And Jason, you performed these the burr holes and the craniotomies for these patients, and you have referred several of these patients for embolization of the middle meningeal artery. That's the artery that is embolized for in these cases.
He does it kicking and screaming.
I'm sorry?
He does it kicking and screaming. There are times I round with the team in the morning, and I'm looking at the films because Jason takes the preponderance of calling. I'm like, dude, what are you doing? So he's coming around. He's still a surgeon.
Usually I say something like, the patient's dying, I have to do this.
Yeah, the patient's like hemiplegic. I got to take him. I was like, okay, never mind.
Hey, Jason, good seeing you again. I remember I saw you in Houston recently. Good seeing you.
Right, yeah, good to see you, Peter.
Just for the audience, just explain what a burr hole actually is, what you actually have to do in order to take these out.
Yeah, so as was explained by Jared, subdural is a type of bleeding below the covering of the brain, the dura. And so the whole goal of any procedure to treat this is to get rid of brain compression from that blood that's laying on top of the brain. And so we have to somehow penetrate the dura, release it, and allow blood to come out. So there are a couple ways. You can do a wide opening craniotomy and open the dura to release the blood. A less invasive way is to just put a small hole the size of really a quarter and open the dura through that quarter and sort of wash the blood out. Usually you put one burr hole in the front, one in the back of the head, and that allows you to kind of wash through. So that's the burr hole method. So those are the techniques I think all neurosurgeons grew up learning how to do some of the simplest procedures that we do actually. We think of those as intern type procedures. So, doing embolization to treat these is certainly new, and I have to admit I'm a late adopter to the procedure, but I think we are getting some good results with it. The question is really patient selection. I'd like to ask Peter and Jared about, you know, what sort of patients are good candidates, what sort of patients are not good candidates for embolization.
So I think people have looked at all kinds of patients. If you look at Jared's paper and other people who study this, you know, people look at primary treatment, you know, so there's data out there on that. There's data on recurrent treatments, you know, people like you said who failed surgery, burr craniotomy, who has subdural hematoma. And then there's also a group of patients that we do adjunct treatment. Some people do it before, right before surgery, right after surgery. And it seems to work in all three groups of patients, even though I think we haven't really parsed it out yet, Jason. But I mean, when I look at literature, it seems to have good effect on all three groups of patients. In terms of me, I think I usually pick the patients with a sizable subdural, like at least 1 centimeter, you know, but I mean, people who have, of course, like you said, kind of life-threatening mass effect, those people like I take to surgery. But I think anyone who can tolerate like a moderate size of hematoma, I think that's a fair candidate. Jared, what do you think?
I would agree. For the purpose of the trial, we're starting in Q4 of this year, the Embolization trial, which is being sponsored by Medtronic. It's going to be a randomized trial over 35 centers utilizing Onyx, which is a liquid embolic agent to shut down the middle meningeal artery. There's basically two groups that we're going to be studying. Those that have very minimal to asymptomatic subdurals, things like headaches or maybe a slight drift in the arm, and doing embolization as an upfront standalone treatment, comparing it to just conservative treatment or watching the lesion. And those that need surgery for the subdural hematoma is the second group, those that come in already with mass effect and neurologic deficit and a sizable hematoma, and we're adding embolization onto their surgical treatment and seeing if it changes the recurrence rate. So those are the two groups that we're studying in the trial, and that's because I think those are the cleanest groups to study in the trial. But I think for real life practice, the most powerful application of this is the patient who traditionally would have met surgical criteria, and we're doing this instead. And I think that has as much to do with the lesion and the presentation of the patient as much as it does with the patient's family support and their level of follow-up, because subdural hematomas generally progress insidiously but slowly. So if someone comes in with a mild neurologic deficit, maybe a few millimeters of brain compression or shift, a 1.5 centimeter chronic subdural hematoma, that traditionally would get taken out. But if you have that patient and their family sit around and you explain to them that the embolization is an upfront alternative and that in the time it takes for the blood to resorb after you've interrupted the arterial inputs to it, if they get worse during that time period, they could always come back and get surgery as long as you have a good patient follow-up and a supportive family or structure around them. And I think that you can push the limit of offering embolization instead of surgery. That's a tougher group to study in a randomized trial because there's a lot of confounders to account for. So the trial itself, we're keeping cleaner, but that's definitely, I think, the most powerful application to this. I'll add one more group that we're just now beginning to really look at. We've collected about 20 or so patients in this group. There's a lot of patients that have subdural hematomas secondary to leukemia or secondary to blood thinners. And these patients are basically left with no option because you can't operate on someone whose platelets are low and that you can't transfuse up, and you can't operate on someone who is maybe on an anticoagulant for a heart valve that you can't take off. And although we're finding a little bit of mixed data in that patient population, we're seeing about 50% success rate. It's still a treatment alternative to a group that otherwise we basically were handcuffed in the past and didn't have any options for. So I honestly think almost every patient with a chronic subdural hematoma can have an MMA embolization as part of their treatment, either as an adjunct to traditional treatment or as an alternative to traditional treatment.
And Peter mentioned that there's a group of patients in which you're doing embolization before surgery, before taking out the hematoma. Is that what you mentioned, Peter?
I don't think that's from Jared's group, but I think you know, I think in Jared's last paper, like he looked at kind of primary treatment and also for recurrence. But I think other people have done kind of preoperative embolization or immediate postoperative embolization as an adjunct therapy to it, you know, and I think just want to add to what Jared said too about studying the group of patients kind of needing surgery, whether the embolization itself can work. So that's what we want to study, you know, because I think we want to, you know, Jared's obviously started his trial design a long time ago, so we want to add something different to the literature. So I think that's a group of patient that we're actually trying to study, is to see, you know, I mean, for this kind of more moderate group of patients who have more symptoms, whether primary embolization can be used instead of surgery. But of course, that's a much harder sell to the patient in some way, you know, because that's not truly standard of care in some ways, right? Those people, as we speak, we operate in them, but I think it'll be interesting to see what we can do. And I think, as Jared said, I think most people can benefit from this one way or the other, you know, so we'll be interested to see what the results of all these studies are at the end of the day.
And I have seen a very diverse way of embolizing the middle meningeal artery. I've seen people that use onyx, others use glue, others use coils, others use particles. Any way that the two of you, or any preference on the embolic material, and why would you like that material instead of others?
I think it's a bit of a dealer's choice with this, because I think they tend to all work well, except the coils. I think at the end of the day, you want to get some material, whether it's particles or liquid embolic agent, into those distal arterioles that are feeding this. And coils, which is really just the proximal occlusion, is no different than bipolaring the MMA at the level of the skull base. And I just don't think that gets to those small arterial feeders. But we haven't seen a difference in the outcomes between particles and liquid embolic agents, at least on a gross scale. But I think that they offer different pros and cons. So we started with particles because they were cheap and they were safe. And the arteries that you don't see on an angiogram that could be potentially dangerous, anastomoses, or connections to important vessels that you don't want to shut down, like the ophthalmic artery that goes to the eye, or the petrosal branch of the MMA, which goes to control facial movement, those tend to be on the order of about 40 to 50 microns. And if you're using 150 micron particles, it's really going to be hard to push something like that into a vessel that you don't see. So it's a very safe treatment. Where I think liquid embolics come in and potentially can offer an advantage to particles is that they're a permanent embolic fixture. And in wedge flow, meaning if you get your catheter very far out the MMA into a distal position, you can really push that onyx into branches that particles won't reach. So in the few recurrences that we've seen, we've gone back and looked at their angiograms, and we've seen a couple of things, or we've retreated them and seen a few things. One is they can collateralize potentially from the opposite side. Also, there can be a subset of patients who have a very large dural feeder from what's called the anterior falcian artery, which comes off the ophthalmic. And this is not an artery that we can get into safely with catheters. Well, with a liquid embolic material, you can push that contralaterally to the other side and even toward the midline where that falcian artery is. So it's very possible that in that small subset of patients who have flow to their subdural from one of these other branches that we can't traditionally access, that liquid embolic agent would be a better solution than particles. But the data is pretty strong in both groups. In our particle paper, we're seeing as a prophylactic adjunct to traditional surgery, so adding it on either pre or post-op prophylactically, we're seeing a recurrence rate of 3.6%. So that compares obviously favorably to the traditional 15 to 20 and upwards recurrence rate. And in the upfront treatment patients, those who meet surgical criteria, we're seeing a 92% efficacy without the need for adjunctive treatments such as surgery or reembolization. And that's with particles. And if you look at some of the other groups that have been heavily more towards the liquid treatments, such as Adam Arthur and Dave Fiorella, they report pretty similar numbers. Now, we're using liquid embolic onyx for the trial, and a lot of that is because the trial is being funded by Medtronic, and you can get a trial through industry in this day and age a lot faster than the NIH. It's just an unfortunate reality. But at the end of the day, we're still going to get really great data and science out of it, regardless of which product you use. And I think once you have an FDA indication for this procedure through a really robust randomized trial, I think physicians will be left up to use whatever they want to use. And I think any of these material work pretty well.
Okay.
My biggest concern, I just think that there's, it goes to the whole problem with interventional right now, with the stroke centers driving, hiring, and training, is that the understanding of the risk to this it's not, as bad as a subdural operation could be, people aren't going blind from taking a subdural out. And my concern, and as we as a field have to deal with this kind of thing, I think we've already seen this kind of behavior with devices I honestly don't think that onyx is any more dangerous than particles. In fact, it may be less dangerous because you actually can see more easily. With the particles, you need a negative roadmap. If you get some reflux, and for the audience, basically this is the way these two different substances appear on your X-ray image. The particles, you're pushing little balls of particles, and you see little puffs coming out of the tip of your catheter. That can be, you have to. It's more intermittent, and you have to have a little more control. Whereas the glue, when you're pushing it, it acts almost like a toothpaste, and you're pushing this glue into the vessels, and it almost arborized, looks like a tree at the end. So it's a little easier to see. But I'm concerned about as this becomes kind of more common, the complication rates. And I think what's important for you guys to do is start publishing on things like we try to publish a paper reviews, but what are the natural collaterals? I mean, people don't, there hasn't been a paper on collaterals off the MMA in years, if you think about it. I mean, it's in like the old textbooks. And that's because this is sort of old news. Well, now it's really, as this becomes more in vogue, it's something that's really important to make sure the average, neurointerventionalist who did a neurology, maybe more primarily stroke fellowship, they get into some community hospital. Now they got a subdural that they can embolize. They just read about it, hasn't had that experience, and they're using onyx. They're just watching they're not careful. What are your thoughts about that? Which do you think is more dangerous without understanding the natural collaterals? Or if you don't have a good working position, which tool would you rather use?
I think liquid embolic is more dangerous in the wrong hands. I completely agree with you. And for the trial, there's going to be a set protocol of where the catheter has to be, a set angiogram of the collaterals that you need to look out for, and obviously serve as exclusion criteria for the procedure. No doubt, if you are unaware of those collaterals, you can definitely push a liquid embolic agent into the wrong vessel if you're not careful. I think if you've got no large collateral to the ophthalmic coming from the MMA, and you're past the petrosal branch, I think particles are certainly safer, especially 150 micron and up. But there's no doubt that the fastest way to ruin a new technique or a new innovation is to get a complication. And in the wrong hands, if you give someone a facial nerve palsy or blindness, which really should be a never event with this procedure. Because
we have seen it happening. We have seen cases of people having the complication. We have, but with just kind of that knowledge, you're looking out for those literally two things. It really shouldn't happen. But there's no doubt that in the wrong hands or practice without the right training or the right knowledge of the anatomy, it could sink an otherwise very promising technique. And Peter, what do you say to the contrarians that say subdural hematomas, if they're asymptomatic, they will reabsorb with time, and whatever we're showing with the results 1, 2, 3 months after the embolization would have happened either way, even if you didn't treat the patient? We have had those critiques.
Yeah, for sure. When we're looking to design our trial, we actually look heavily into that, and it's actually not true. So we looked up like 30 plus studies, kind of 500 patients in total with these subdural hematomas that we observe, and actually the recurrence rate is hard to believe, but it's actually about 20% also. So it's not, not recurrent. So people needing subsequent needing surgery. So I think sometimes we all think that. I think we all think positively. We all remember the patient we have with small, smear subdural that went away on follow-up. That is not an issue. But if you look in the literature, I think critically, the results of observation, even on these milder, smaller hematomas, are not as favorable as we think. So I think it totally justifies, for example, what Jared is saying, to randomize them, whether it be observation or MMA embolization, which is in the right hands, I think, a low risk procedure. So I think, so I guess, Rafi, the answer to your question is the event rate of those patients needing surgery is not as low as we think. It's probably still closer to 20% overall.
Okay. Any questions from the audience, David, that you've seen coming through Instagram?
There was questions about the glue stays in all the time. Once it's in, it's in. There were questions about, wait, there was one quick one here. I mean, my biggest question is, I could ask you, is, there was one about what occurs when a patient has hemophilia and bleeding along with a subdural hematoma, which we talked about. There's probably a better treatment for patients with bleeding disorders. I guess what do you treat patients that are asymptomatic? Say with a small subdural. Say you have a small chronic subdural and it's my grandma or my mother. She has a little bit of a headache and she's got a chronic subdural 1 centimeter. Would you guys treat that?
I would at this point.
Would.
Yeah, I mean, early on, we obviously wanted to show efficacy in a group of patients who were refractory. So we didn't treat those patients unless we followed them for 2 months plus and saw the subdural wasn't going away or they were still having headaches. We let them kind of suffer for a bit because we wanted to, be sure that it wasn't going to naturally resorb on their own. Now seeing the results, seeing how safe it is, and going through the wrist, going through a radial puncture, sending someone home the same day, an hour and a half later after a 20-minute procedure, seeing the safety protocol of it. I have what's that?
You're doing it awake?
I'm doing it awake.
Radial awake?
Radial awake, no anesthesia, home an hour and a half later, and then they're back in the office in 2 weeks. Given the fact that the undertaking for this procedure is so minimal, that I don't see the benefit of letting somebody wait out the natural history potentially, especially because as Peter rightly pointed out, natural history is worse than a lot of people in the community think. And the procedure is so safe and unencumbering to one's day, and you're not in the hospital, that, yeah, I have a much lower threshold now to treat. And we now have more believers in this, that the neurologists as well have signed on to referring their patients, even in those early stages, for treatment.
Are you doing it radial, Peter?
Yeah, and I think, especially in the group patient that Jared mentioned, like I work at MD Anderson, and we have these patients too, like the leukemia patient, really from a cytopenic, and I think that those are the perfect patients to do radial on. You don't have to worry about groin hematoma, and I think that the support you need for this system is so low. So now I actually, everyone I do radial access for this, and I actually just use a diagnostic 5 French catheter into the external and micro catheter out. So I think, then you're just talking about TR band after, I could do them awake, just like Jared mentioned. I think it's, even the procedure itself, I think is heading towards that way from all of us who are doing it. So I think the pressure of treating patients with data accumulating is actually lower and lower now, David. So I would, in our study too, like we would treat the patient, like you mentioned, people with a sizable, like centimeter hematoma with midline ship and no symptoms. I think that patient deserves the treatment also.
I actually had a patient about 2 weeks ago that had such a bad arch. I couldn't get there. I mean, it was, the common, the innominate artery where the subclavian and the common carotid joined, the curve was so bad. I was able to get the wire up, but I tried everything. I tried stroke catheters, I tried a neuron, I tried a smaller neuron, I tried a stiffer wire. I tried with a VTEC to hold the curve and get the thing around. I finally just stopped because his art, I couldn't get it from femoral access either. And I think one of the things is that, and I also don't like doing these patients awake. I mean, a part of it is that they tend to be a little bit older, more confused. I like to see, especially if I'm using particles, I'm using negative road, it's magnified, because I just don't want to cause a complication. I think that it's so interesting to see what you guys do this. I really shy away from this kind of stuff awake. Plus it hurts when you inject sometimes. I know you can give some lidocaine. Obviously, if you guys are doing great jobs, you guys are super talented. What's the secret to the success of doing this awake with radial? And how often do you abort?
I think you bring up a good point. I mean, the only, as long as you know the anatomy, the only other way to kind of hurt someone here is an elderly person with a tough arch and who has plaque and flicking something off. And I think having a healthy degree of caution and stopping the procedure is important as well. If someone has an MMA that primarily comes off the ophthalmic, not a candidate. If someone has a big collateral, not a candidate. And I think if somebody has a really tough arch, you've gone out there a few times and you can't get something up there, we stop.
Right.
We stop.
Yeah.
And
How often is that? Do you find it easier? I mean, depending on the radial or femoral, have you had to convert from radial to femoral for a bad arch? Do you abort more frequently from a radial approach? Do you have patients that are awake that just get irascible and start moving, and you just have to abort for that reason, have to intubate? What's the, how patient should we be with this approach, as if we haven't done it that way?
Yeah. I've converted radial to femoral and femoral to radial, in both cases if one side didn't work. If they're confused, I put them to sleep. If there's a language problem, I'll put them to sleep. If they're post-surgical and still a little bit tired from the anesthesia surgery, I'll put them to sleep. It's, but a lot of patients, because it's an insidious, but they're generally not tunded. Most patients in a head holder with tape around their head, who can follow commands, I think most of them hold still enough.
And do you inject local into the meningeal?
Not if I'm doing particles. If I do onyx, which is DMSO,
yeah,
a little bit of fentanyl and intraarterial lidocaine beforehand.
And what percentage of your case are you doing with particles versus onyx?
50-50 now.
What makes you decide one versus the other besides the trial?
You know what? That really was it. I mean, at the end of the day, when we knew that we would have an industry-sponsored trial with onyx, the onus was to really get the technique down and figure out the right arteries to be in wedge flow, to how long you typically have to build a plug, not build a plug for onyx. And I wanted to really make sure that we were facile with all the pitfalls and pearls with that before we went out and trained the other centers. But 50-50, yeah.
Peter, what about you?
I use only particles, and I think just to kind of add to the points everyone has mentioned about the safety, I think, all these anastomosis comes off fairly proximal. I think if you're selective into the branches of the MMA in the front and parietal branch selectively, I think it's really quite safe. I think the advantage of doing them awake, David, of course, a lot of these are older people, have comorbidities, heart disease, and so forth. It's really nice to able to avoid, I think, general anesthesia. And I think if I usually use particles, Rafi, and I put them selectively into the front and parietal branches, and I think if you're in that and use 150 microns particles, it's really quite safe, right? I mean, they can wiggle around a little bit. I don't think that's a big deal, in my mind.
What microcatheter do you usually use?
I just use my standard coiling. I use a 14 catheter, kind of big enough that the particles don't clump and block up the catheter, but still small enough I can pretty easily navigate into each branch individually.
And Jared, you use a DMSO compatible microcatheter, I guess, because
I don't use onyx, so I just but I use Ashland 14, so that's
what about Jared? What microcatheter do you use?
I use a duo. Something DMSO compatible, but also something that large enough not to get clogged with particles, but very easy to navigate.
Okay.
Just to summarize for the audience, a subdural hematoma is a fluid. It's not an acute problem. These are not acute clots. These are patients that have had, sometimes unknowingly, developed a blood clot in their brain that over time turns into more of almost like an oily consistency that can create mass effect and push in the brain and cause neurological deficit. Early on, headaches, confusion, maybe just, depending on the patient, but they can cause a focal deficit. And there are two ways to treat them. Open, meaning putting a hole in the head and draining it, or through a catheter, through the radial artery in the wrist, or through which is a newer approach, or for the femoral artery in the groin, and going up into the arteries that feed the cover in the dirt and injecting with agents that will block those vessels and prevent those clots from getting worse. And Jared and Peter and Rafael, for that matter, are some of the leaders. And certainly Jared and Peter but Jared really was the first one to really start doing this. Peter's running one of the biggest clinical trials with this. And Rafael, I obviously is our guy at Lenox. But this is a new procedure and for a very old disease. And I thought, as far as historic things go, I just find it just so astounding that this is probably one of the first surgeries that was probably done by human beings on one another. There are holes in people's heads dating back to the Incan and the Peruvian civilizations, probably draining blood clots, because you can do this in awake patients, even open surgery. It's painful, but not like cutting a leg off. And so now literally probably 1,000 years ago this was done, or longer, and yet we surgically have been doing this exactly the same way. And here comes this brand new way that wasn't obvious, and you've probably going to change the course of what was a very standard procedure for neurosurgery. And I just thought, have you thought about your place in, neurosurgery history? We're looking back 50 years, that's a pretty big contribution to make. Have you thought about that kind of thing? Like, is a legacy, and the idea that you guys were the early adopters, that must make you feel really good.
Oh, thank you. That's very, very complimentary. Probably too complimentary, to be honest. But, I was floored as well, just like you, David. I mean, for something that we've been doing the same way. And what was also really interesting was in designing the trial, and going back and looking at what's considered standard of care, standard medical therapy, standard surgical therapy. There's so little that we understood about its natural history, and we've just been treating it the same way over and over. Sometimes people will be on steroids for these. There's really no great data for it. There's some data out of China that anti-cholesterol medications can help. It's not really great data. You have people who operate by putting a burr hole in. Some people do 2 burr holes. Some people put a little drain bedside. Some people do a craniotomy and strip the membrane. Some don't. There's so many ways to skin the cat of this problem, which is the most common neurosurgical condition by 2030. 60,000 new cases per year in the US every year. And we have known so little about it for so long, and it's been essentially right under our noses to a certain degree the entire time. So I think one of the best things that's going to come out of this trial, regardless of the results that we find, is I think we're going to have an exquisite understanding of this very common neurosurgical pathology that I don't think we really understood before.
What do you think? Again, conventional wisdom is something we all fight. All of us. Peter, what were the things that got you to buy into this early? What was it? What was the moment when you said, I really want to try doing this?
I think David, I think it's analogous to what Jared and you've been talking about. I think I saw the results. The results are good. I think that's one thing. And then the technique, the approach is minimally invasive compared to what we used to do. So I think in my mind, if you can, have a better outcome with a more minimally invasive technique, that's real progress in science and medicine. I mean, it kind of makes you think a little bit about like the pipeline and flow diversion. If you can do something that's simpler, less invasive, but achieve a better outcome, that's real progress in medicine. So I think that I'd be very happy that I kind of embark on this journey, just like Jared did too. And I think this will be good, once we do the studies.
You guys comment a little bit on the science behind this. I know, Jared, you saw these pathological specimens, but we know that dura is really very vascular. It's got all these collaterals all over the place. Also, this isn't like when you open these things up, it's like there's blood vessels. It's not like an AVM. It's not like it's not like a vascular malformation that bleeds. Yeah, it's got little hemorrhagic membranes and stuff, but it's not like bleeding profusely. Why do you think this works? What is it? What's the science behind the formation of membranes or the fluid conversion of blood? And why does this disrupt? And it works relatively quickly. Like, you see them go away. When I first did this, I was scanning people every few weeks. It's just when you see a positive, it's almost like magic. I had one guy, bilateral subdurals. This is the thing that converted Rafa, a guy with bilateral subdurals, and he had small ventricles from having compression. This fluid space in the brain were reduced. We did bilateral, and he basically, like 4 months later, both clots are gone. His ventricles are like 30% bigger than they were pre-op. It's just like, and I showed the 2 scans. It's like magic. It's like, and we did not do surgery. What's the science? What is the science here?
I think one of the most interesting things on the first few patients we looked at was their diagnostic angiograms, because their MMAs just looked different than the MMAs of a patient without a subdural. You saw these little fingers of arteries that had basically grown and formed over the convexities, over the sides of their brain that had the subdural hematomas. And I think it's an inflammatory process. I think tumors behave this way. I think injuries behave this way. If there's an inflammation in the body, that inflammatory process recruits arteries. It recruits it to send cytokines. It recruits to send oxygen. there's intraarterial treatments for brain tumors that obviously Rafa and John are very involved in. I mean, I think arteriogenesis is just a fundamental epiphenomenon of inflammatory processes. And I think subdurals are just this chronic inflammatory state. Now that's all theoretical, but I think that the angiograms that show the little fingers form point to it. I think the CAT scans after this procedure where you see the contrast inside the subdural inside the subdural cavity from a transarterial approach confirms a connection. And I think the pathological membranes is also, just more evidence for the fact that what starts out as a torn vein, whatever creates those membranes is probably an arterial-based inflammatory process.
Yeah.
We have two questions through the chat. One says, this technique is used as adjuvant therapy for cranny versus burhole or versus sepsis. You guys want to address that?
I think it could be used as adjuvant therapy for all three. We use it for all three. Sepsis is a very specific type of drainage for a specific type of subdural. It tends to work well on very homogeneous, non-membrane, non-loculated subdural. So the surgical treatment of a sepsis is not as efficacious as a burhole or craniotomy in general, if you look at the literature. But in the right patient who responds well to a sepsis, we will use it as an adjunct in those as well as the others. The only thing with the craniotomy is you can sometimes cut through the MMA with the craniotomy. So embolizing it afterwards, if you've taken the MMA already, you may not have quite the same result. I know for the trial, we were mandating that if you're doing this in the second group, those who are getting randomized to embo plus surgery versus surgery alone, the embo has to happen before the surgery so that the MMA is in its native state.
I want to show, I was able to cover PHI. I just want to show that case to the audience because we've been talking about it. We haven't shown, we all know what this stuff looks like, but the majority of certainly our Instagram audience doesn't really know what it even looks like. Let me just share my screen real quick. This was the This was the case that I showed Rafael. And so on the right-hand side is a patient with bilateral chronic subdurals. These spaces here, there's even some acute blood in them, all this dark area. And you can see the spinal fluid space in the brain are these are the CSF spaces. They're called the lateral ventricles. And these are small for, this guy was, I think, almost in his 80s. Long story short, on the right, on the left is the scan afterwards. You can see totally gone. Those fluid collections are gone. So, this is what this can do without opening someone's head. That's the kind of thing that we can accomplish. And it's truly magical. And I think I still don't quite understand it. I agree it's vascular, but it just seems like it's such a vascular tissue. And the fact that it works and it's prolonged, even with particles, which we, theoretically are temporary. But it's just an incredibly important contribution to our business. It really is.
Go ahead, Peter.
I have a question for Jared about the technique. When you use Onyx, Jared, you're talking about penetration, to arteries like the anterior falcine, and things like that. Do you build a plug, for your injection, or you use a balloon, or what do you do for the injection?
I actually don't. When I first started doing the Onyx, I wanted to see if building a plug would help me push it further. And for these procedures, it really doesn't, because I think the vessel gets to be so small distally that I just take my duo into wedge flow to the point where it won't go any further. And then it's really that first push, and that does all the work. And sometimes it will collateralize down. If, let's say I'm in the temporal branch, it'll collateralize up to the frontal feeder or vice versa. But if it doesn't, I'll then selectively catheterize the other branch and get that territory as well.
We have another question from the audience. How long do you wait after the evacuation to proceed with MMA embolization?
The times I've done it, I usually do it it's not emergent. I would do it in the same hospitalization, maybe like a day or two afterwards. Jared, what do you do?
Same, either the day before or the day afterwards, as long as it's in the same hospitalization. Yeah.
Jared, you'll catheterize the two MMA branches separately?
For particles, I won't. I'll park the catheter proximal to that bifurcation because I want that laminar flow to take the particles distally. For a liquid embolic agent, if my first push doesn't push through to the other branch, then I will catheterize the second one.
The thing is, well, we had a case where the frontal branch came off the ophthalmic, and there was only a parietal branch, but the clot was all frontal, and it still went away.
Did you particled or you liquid embolic?
Particle. Parietal branch is still resolved, even with not even directly, there was actually in a different distribution, not, there was some overlap.
Yeah.
That's just crazy.
I mean, but those membranes can be the whole hemisphere, even if that focus of blood can be like in one region. Those subdural membranes almost are holohemispheric. So yeah. I think you're still getting something out of that. But that's interesting. Wow. Yeah.
There's another case I called you about a shunt patient that had a subdural from a shunt. That you said I ended up doing it because she had a coagulopathy. I actually was going to send her to you because she was so upset. She just finally decided to stay. But we actually embolized it, went away. What's your guys, when you have subdurals with shunts, how those turned out?
Sure. We've had a few as well where you've already dialed up the shunt and they still have subdural collections. They're still draining something through a closed off shunt, or even a tied off shunt. Sometimes there's just and I have done a few of those as well. Not enough to, I think, make a strong statement on efficacy, but I've done them in the exact same states that you have, where your hands are kind of tied, you've tried everything else, or they have a coagulopathy or something that makes them a candidate for this.
Peter?
No, I've actually heard of a few of these cases, but I've never done one myself,
This lady had low platelets. She had like a platelet count of 50 and had developed a subdural from a shunt. And I was like, I had to call Jared about it. I mean, not wanting to, and it wasn't going to work. And, but again, it's going to the whole thing when you have a coagulopathy, it makes a lot more sense to try, even though Jared said, in general, they don't do quite as well, but this worked perfectly well. And again, these are problems that we really didn't have great solutions for before. These would become more chronic problems that keep collecting and recurring. Yeah. It's been a godsend for certain patients.
And I think another good group of patients, David, now you're talking about like the little bit of non-standard patients. I have a few patients, who had like a new coronary stent or something. They're on antiplatelet therapy and they have a subdural, so we even did a few that we just kept the, like the subdural is not so bad, but they're kind of enlarging. So we even did it on antiplatelets and it worked quite well, So I think this may be a procedure that would be like the thrombectomy, like it works great, for most patients, like Jared said, so we'll, it'll be interesting to explore all these different groups of patients beyond what is in the trials being studied right now, I think.
I've been obviously gotten a lot of exposure with this group. Maybe each of you could tell the audience, Jason and Rafa included, how you ended up, maybe in a minute or two, how you ended up where you are, and why you do what you do, and because we want to inspire these kids and educate them at the same time. We're trying to use this as an opportunity to draw people together. It's obviously a very challenging historical time, and I think generating good mentors and good leaders is important. So seeing you guys in the next generation is wonderful for me to see. What do you have? What advice do you have to give to them? How did you end up where you are, and what would you tell them if you were getting started now? So why don't we go Peter, Rafa, Jason, and we'll finish with Jared.
Yeah, it's actually kind of interesting. So how I got into neurosurgery was actually through the subdural hematoma. Like I had a great mentor in Toronto who let me put a burr hole in for this particular disease, So I thought it was, very amazing, that they did that. So actually that was what got me started in becoming a neurosurgeon. I'm coming full circle, David. It's from a chronic subdural hematoma from a burr hole drainage. But I think at the end of the day, I think what we do, I heard it from you and others too, is really like the passion that drives this, at the end of the day. So I think if we keep having the passion for the patients and to cure the disease, then that would serve us well.
Raf?
Yeah, so that word passion obviously is critical when in anything you do in life. To do it well, you need to love what you do, and you need to, as a high school student, college student, you need to find what moves you, What keeps you interested in the middle of the night, just thinking about how you can be better at it? Looking for mentors and finding someone that you can emulate, someone that you can that you feel proud to imitate somewhat in your career. We all have the voices of our mentors in our head, and it stays forever. Find people that you can collaborate with. Working together with others is always not only productive, but gratifying. That's why teams in sports are so exciting, because they work together towards a common goal. And in what we do, we work in teams. You have seen David, Jason, and the rest of our team here at Lenox. We are proud of our collaboration and teamwork, and work very hard. Don't give up. That's where the grit comes into play. Study hard, spend your hours learning in what we do. For example, is about learning anatomy, learning the craft, learning how to avoid a complication. If you maintain that stamina throughout the years of high school, college, medical school, residency, you're going to be extremely successful.
Well, I got into neurosurgery basically by exploring different things while I was in medical school. I started off in a research laboratory, trying to understand brain tumors a little bit better, and that gave me an opportunity to get into the operating room and see what it means to remove a brain tumor. As a student, I was just getting those samples and bringing it back to the lab, but I was really intrigued by the technical aspects of surgery and the type of detail that micro neurosurgeons had to utilize to do what they did, and I was hooked. I spent a summer after my first year of medical school doing this type of research, and I kept doing that, and I kept getting into the operating room more, and I just really liked it, so I stuck with it. So that's kind of my story there.
I first took an interest in philosophy when I was younger, but I found as an undergrad that I liked the way that neurobiology answered the questions of the brain and mind more than philosophy did. But I've always been in awe of the brain, and I wanted to obviously get my hands on it and work with it. The stakes in neurosurgery are very, very high, and that can certainly add to a degree of stress and consternation that comes with this job, but it also adds to a really great sense of meaning because you're working with something that's of the utmost importance. Neurosurgery is such a nascent field compared to a lot of other fields in medicine. So the amount of technology and innovation and progress is faster than I think most other fields of medicine. Endovascular in particular is probably amongst the youngest of the fields of an already young specialty in neurosurgery. I finished my training just under 10 years ago, and I'd say 3/4 of what I use on an almost daily basis in my practice didn't even exist when I trained. So there are very few other fields in medicine where you are witness to that kind of revolution, part of it, and seeing the change literally year to year. So it's incredibly exciting to be in this field.
Finish up, Raf?
Well, thank you, Peter. Thank you, Jared. Obviously, like David mentioned before, you're revolutionizing our field. You're revolutionizing the patient care, and many more patients are going to benefit from these less invasive techniques. Jason is going to lose some business, but at the end of the day, many more people are going to benefit from this. It's a pleasure to have you with us today. And again, Peter, congratulations on your new position. Amazing, and good luck. I know you're going to do an amazing work and elevate the care in your new hospital. And
good luck with COVID.
Yes.
Oh, thanks. Yeah, we're quickly heading towards where you guys were 2 months ago, unfortunately. But thanks, David. Thanks for the kind words, and thanks for having me, Ravi and Jason and David. Really appreciate it.
And Jared, a pleasure to be your neighbor from 10 blocks away, and looking forward to further collaborations.
Same here, and thank you again for the opportunity to speak today. I enjoyed this a lot.
Thank you
Take care,
all.
guys.
Thank you.